Respected chairpersons, moderator, learned audience. I hate sarcoma. Specifically, I hate thoracic sarcoma. Because whenever patient come to me, it's truly inoperable stage, or he used to came to give me pain to my consultants, oncologists, Shajal, you can say better than me. Only hope is it is rare. It is 1% of malignant in general. It arises from connective tissue like chest wall, pleura, lung, mediastinum. I'm very much comfortable with lung surgeries of lung cancers, esophageal cancers, diaphragmatic as well as mediastinal. But in this sense, I don't know from where it is coming out, and to some extent how far I will resect is very difficult. So no age is immune to hep sarcoma. I got 2 months baby having blastoma. So Ewing sarcoma, yes, I prefer it because our oncologist can reduce it by chemotherapy, radiotherapy, then I can resect it. So it have a very good result. Chondrosarcoma also this, but osteosarcoma, it recurs. Malignant fibrous histiocytoma, it also recurs. Angiosarcoma, I got only 2 patients. Rhabdomyosarcoma, it is worst one. Mesothelioma also. There's a spectrum of clinical presentations there, mostly large heterogeneous masses. All the presentations, solitary pulmonary nodules, it bears a very good result. You should not to get some solitary pulmonary nodules. Symptoms due to compression and invasion. Both are difficult to me. Diagnosis by obtaining tissue, only core biopsy and by resected samples. Treatment in our settings, we must have medical board, oncologists, radiation oncologists, and other faculties like cardiologists or radiologists and histopathologists also come with us. But challenge is here, sir, knowing the disease status. Every patient want to survive, want to have a disease-free life, but sorry, outcome or consequences are very worst. Patient compliance. Patient, whenever gets some relief, they used to fly away. They are lost follow-ups. So their heights of expectations are diminished there. And cost, definitely, it's a very costly procedures. All of cases I've done in Bangladesh Specialist Hospital. So in this scenario, it is very difficult to make a chain with discrete beats. This young lady underwent a rhabdomyosarcoma in her right thigh 18 months back. She was warned about disease and its consequences, chance of recurrence by the surgeon himself. She consulted the oncologist after getting worse. No adjuvant therapy she received. She came to me with pleural effusion. I was asked to go for pleural drainage and pleurodesis. I introduced camera and I found a huge mass on the pericardium, and it was very difficult whether RA or it is pericardium, it is very difficult. So I have done angiogram, pulmonary angiogram, and I deferred it from, it is not in the heart, artery, but rather in pericardium. So what next? I didn't take biopsy because it may injure and tremendous bleeding can occur. It's possible for me. I can go for all resection of the pericardium, pulmonary root of the pulmonary arteries in cardiac setup, but patient yet not received the treatment. This boy diagnosed as mediastinal dermoid by core biopsy. So though dermoid is a very simple case, we operated on it. But during surgery, it was difficult. Adhesion was there, invasion was there, and effusion, only small effusion was there. So recovery was acceptable. Are you happy? Sorry. Now 2 new diagnoses appeared. One is seminoma by one center and alveolar rhabdomyosarcoma from another center. I referred it to my consultants, oncologists. So they made immunohistochemistry. Finally, it revealed primitive neuroendocrine tumor. So 4 diagnoses in a simple case, solution simple, but dilemma was, and pain was significant. Chondrosarcoma. I like it because it causes swelling, and after swelling, patient used to come to doctor. It's very simple to make diagnosis. Challenge lie in location, extension, and we see it extended into the diaphragm, into the hepatic bed, the rib cages, and we removed all. No hepatic adnexal invasion was there, so repair done with muscle only grafts. And patient is okay now. This is pleomorphic sarcoma. Patient treated with chemotherapy. Initially, it was 6 centimeter growth on left chest. He was asked for surgery, but he was not responding. Now is a very big growth invading the chest wall, left upper lobe of the left lung, and mediastinum. My team totally disagreed. Again, medical board, because patient attempted 2 times for suicide. That's why, again, Shajal, you can remember it. Yeah. Even abroad oncologist also on the screen, they decided go for it. So it was a hectic 11-hour surgery. We have done excision of the whole mass along with 4 ribs, left upper lobe, tailoring thoracoplasty, and free flap reconstruction by my plastic surgeons. And here was vascular surgeon was there to save the brachial and axillary arteries. Neurosurgeon was there to save the brachial plexus. He recovered nicely, even only 1 day in the ventilator or in the ICU. Sorry, not in ventilator, but in ICU. So what about the patient? He came to me, this picture, he came to me with a scooty for a follow-up. After 3 months, came to me on a scooty and having a very big ice cream. And after 6 months, he had COVID positive and expired. So only in COVID, not due to sarcoma. So I hate it, but in this case, I love it. This patient, core biopsy revealed inflammatory lesion from chest, 1 mass left side, it diagnosed neurofibroma. So both are benign entity. Surgery done. Thigh mass revealed fibrosarcoma. Thoracic mass revealed liposarcoma. Immunohistochemistry confirmed liposarcoma. Is continuing chemotherapy under Professor Kamru Jaman Chaudhary. This is again a very nasty case. Synovial sarcoma received chemotherapy, no response, tumor compressing, red vessels, upper lip compressing, and distal ischemic necrosis of the hand. So I had to get, it is truly inoperable, but patient agreed to sacrifice his hand and upper chest. So we made it. We had a whole 4/4 amputation was done along with chest wall. So result, again left from follow-up, a recurrence is there. What next? So should I go for surgery? Sorry. Good news is rare. Early diagnosis is good. It is truly beneficial. I need sarcoma clinic. I've seen in the abroad. Sarcoma clinic is there. So it is a time to make a sarcoma clinic. New adjuvant therapy are what it makes the more discomfort. It should be trace house now. So from my part, again I said it's too difficult to treat thoracic sarcoma. Thank you very much.